There are 5 pills sitting in the medicine cabinets of millions of Americans right now. Not illegal drugs, not black market compounds, medications that a doctor prescribed, that a pharmacist filled, that you have been taking faithfully, some of you, for years. And I need to be direct with you about something that almost no one in a clinical setting is going to say out loud. After the age of 60, these 5 medications carry risks that are rarely explained at the point of prescription, risks that compound quietly with every passing month, and risks that in many cases can be addressed with targeted alternatives that cost almost nothing. This is not about stopping your medications without guidance. That is not what I am saying, and I want that on record from the very first sentence. This is about the information that gets left out, the mechanism your prescriber didn't have time to explain, the nutrient depletion nobody warned you about, the biological change that happens inside your body after 60 that makes a medication your doctor learned to prescribe 30 years ago land very differently in your system today. Because here is the fact of the matter. The clinical guidelines that drive most prescribing decisions were developed from research populations that were younger, often male, and not managing 4 other conditions simultaneously. Your body at 65 is not the same organ system that clinical trial data was built around. It metabolizes drugs more slowly, it depletes critical nutrients faster, and it has significantly less physiological reserve when something goes wrong. The 5 pills I'm about to walk you through, I would not take them after 60. Not because they have no value, but because for each of them there is a specific mechanism that becomes significantly more dangerous after 60, a specific alternative that addresses the same root problem, and a conversation you deserve to have that has almost certainly never happened at your appointments. Subscribe to this channel and hit that like button. Right now, we are building toward 100,000 subscribers, and every person who joins makes it more likely that the next person who needs this information actually finds it. The first pill is calcium supplements. Not dietary calcium, not the calcium in your sardines, your yogurt, your cooked greens. I mean the tablets and chews, the 600 milligram caplets that have been marketed at women over 50 for 3 decades under the banner of bone protection. Here is the mechanism nobody explained when that supplement was recommended. When you eat calcium in food, it arrives packaged inside a matrix of cofactors, vitamin K2, magnesium, trace minerals that actively direct calcium into your bones and away from your arterial walls. The food matrix does that routing automatically. A calcium tablet does not. It delivers a concentrated dose of calcium into your bloodstream without those routing instructions. And what the research has found, including a significant analysis published in the BMJ involving nearly 24,000 participants, is that isolated calcium supplementation is associated with an elevated risk of arterial calcification and cardiovascular events, particularly in people over 60. Think of calcium in a supplement as a delivery truck with no address printed on the package. It shows up at the circulatory system, and without vitamin K2 acting as the routing instruction, it deposits in the nearest available surface, the lining of your arteries. Over years, that calcification contributes to arterial stiffening, elevated blood pressure, and increased cardiac risk. The cruel irony: the supplement prescribed to protect your bones may be quietly hardening your arteries at the same time. What I would do instead: get calcium from food. Sardines with the bones intact, 3 ounces, delivers over 300 milligrams alongside natural cofactors. Full-fat plain yogurt, cooked kale, sesame seeds. If supplementation is genuinely necessary following a conversation with your clinician, it must be paired with vitamin K2 in the MK7 form, 100 to 200 micrograms daily, which activates the proteins that direct calcium into bone and away from vessel walls. And with magnesium, which regulates calcium at the cellular level. Never calcium alone. The routing instructions matter as much as the calcium itself. The second pill may be sitting next to your coffee maker right now. Proton pump inhibitors, omeprazole, pantoprazole, esomeprazole, sold under names like Prilosec, Protonix, Nexium. These medications block the acid-producing pumps in your stomach. They are extraordinarily effective at relieving the burning sensation of acid reflux. And they were designed for short-term use 8 to 12 weeks. But somewhere between the prescription pad and the pharmacy refill, short-term became indefinite. Research consistently shows that a significant portion of long-term PPI users have been on these medications for years with no reevaluation of whether they are still appropriate. Here is what happens inside your body during that time. Stomach acid is not the enemy your heartburn makes it feel like. Stomach acid is how your body extracts vitamin B12 from food. It is how you absorb iron. It is how you activate zinc. It is your first line of defense against pathogenic bacteria entering through your mouth. When you suppress it aggressively, month after month, year after year, those processes are compromised in ways that produce no obvious warning. Research published in JAMA found that long-term PPI use is associated with a significantly elevated risk of vitamin B12 deficiency, and B12 deficiency after 60 does not just make you tired. It produces neurological changes, numbness, balance problems, word-finding difficulty, cognitive fog that are consistently misdiagnosed as normal aging or early dementia. There is a specific mechanism that makes this worse after 60. Gastric acid production naturally declines with age. A person at 70 is already producing meaningfully less acid than they produced at 40. When you layer a powerful acid-suppressing medication on top of an already reduced baseline, you drive the system into a state it was never designed to sustain. The downstream nutrient deficiencies compound silently with every passing month. What I would do instead? For mild to moderate reflux, the root cause is almost never excess acid. It is a failure of the lower esophageal sphincter, the muscular valve that prevents stomach contents from moving upward. The triggers are specific and addressable: large evening meals, lying down within 2 hours of eating, alcohol, carbonated beverages, and in many cases, excess pressure from a bloated, poorly draining colon pressing upward against the stomach. Address those, and for many people, the reflux resolves without a pill. For people who genuinely require acid management, DGL, licorice D-glycyrrhizated licorice, soothes the esophageal lining and supports mucosal repair without suppressing acid production. If you are currently on a PPI, do not stop abruptly. Rebound acid hypersecretion is real, uncomfortable, and can persist for weeks. Ask your prescriber about a supervised taper. And at your very next lab draw, request a B12 level and a serum magnesium level. These are the first two casualties of long-term PPI use, and they are almost never monitored. The third pill is statins. Let me be precise, because statins exist on a spectrum, and this matters enormously. For people who have already experienced a cardiac event, a heart attack, a stroke, a coronary stent placement, the evidence supporting statin use is substantial, and I am not suggesting otherwise. But for the large and growing population of people placed on statins for elevated cholesterol numbers alone, with no prior cardiac event, the risk-benefit calculation after 60 is far more nuanced than the prescription implies. Here is the mechanism nobody mentions. Statins work by inhibiting an enzyme in the liver called HMG-CoA reductase. That enzyme produces cholesterol, but it also produces coenzyme Q10 or CoQ10. Every statin user is simultaneously depleting their body's own production of CoQ10. And CoQ10 is not a peripheral supplement. It is the molecule that sits inside the mitochondria of every cell in your body and powers the production of cellular energy. Your heart muscle, the hardest working muscle you own, contracting 100,000 times every single day, depends on CoQ10 more than almost any other tissue. The result of prolonged CoQ10 depletion is not subtle. It presents as the muscle aches, persistent fatigue, and exercise intolerance that a significant percentage of statin users report and that are too often dismissed as simply getting older. After 60, mitochondrial function is already declining naturally. Statin-induced CoQ10 depletion accelerates that decline at precisely the age when you have the least reserve to absorb it. What I would do instead: if you are on a statin, take CoQ10, specifically ubiquinol, the reduced, directly usable form, 100 to 200 milligrams daily with a meal that contains fat, because CoQ10 is fat-soluble and requires dietary fat for absorption. This does not undermine the medication. It addresses a documented depletion that the medication creates. And ask your prescriber one question that rarely gets asked at follow-up appointments. Has my 1-0-year cardiovascular risk score been recalculated recently? Because that number changes as you age, and the calculation that justified initiating the medication may look different today than it did 5 years ago. Before we get to pill 4, I need to pause and draw a clear line. There are situations where nothing I describe in this video is an appropriate substitute for careful medical management. If you have been diagnosed with heart failure, chronic kidney disease, a seizure disorder, or are currently managing cancer treatment, please do not modify any medication regimen based on a video. The nuance in those situations requires direct clinical evaluation, full stop. What follows applies to reasonably healthy adults over 60 managing common age-related conditions. If you are uncertain whether that describes you, your prescriber is the right person to ask. The fourth pill is long-term NSAIDs, ibuprofen, naproxen, and high-dose aspirin taken regularly for chronic pain. These medications are available without a prescription, which creates a psychological impression of safety that the pharmacology does not support. After the age of 60, the kidneys have already lost a meaningful percentage of their filtration capacity. Research consistently shows that GFR, the standard measure of kidney filtration rate, declines by approximately 1% per year after age 40. That baseline decline means your kidneys are operating with significantly reduced reserve. NSAIDs constrict the blood vessels that supply the kidneys. In a younger person with full renal reserve, that constriction is tolerable and temporary. In a person whose kidneys are already working at reduced capacity, chronic NSAID use can accelerate kidney function decline in a way that produces no obvious symptoms until the damage is significant. There is no pain in the early stages of declining kidney function. It is entirely silent, and the first sign is often a lab result that nobody ordered because nobody thought to look. The second mechanism, after 60, the protective mucus lining of the stomach and intestine becomes thinner and more vulnerable. NSAIDs work by inhibiting prostaglandins, which are the compounds that maintain that lining. Regular NSAID use, even 2 or 3 times per week, is associated with substantially elevated risk of gastrointestinal bleeding in adults over 65. Emergency admissions for GI bleeding in older adults who take over-the-counter NSAIDs regularly are a documented preventable pattern. Suppressing the pain signal while the inflammatory fire keeps burning underneath is the pharmacological equivalent of unplugging your smoke detector and going back to sleep. What I would do instead, for joint inflammation, the root cause in most cases is a combination of local inflammatory load and connective tissue degradation that NSAIDs temporarily mask but do not address. Topical diclofenac gel applied directly to the painful joint achieves meaningful local pain control with a fraction of the systemic exposure. Omega-3 fatty acids, 2 to 3 grams of combined EPA and DHA daily from high-quality fish oil, reduce the systemic inflammatory signaling that drives joint and muscle pain at the source. And magnesium, chronically deficient in the majority of adults over 60, plays a direct role in regulating the inflammatory pathways involved in chronic pain. These are not placebo interventions. They address the mechanism rather than silencing the signal. The fifth pill is the one most people are reluctant to discuss because it is tied to something they feel they cannot function without. Sleep medications, benzodiazepines like Xanax and Valium, and the newer Z drugs like Zolpidem sold as Ambien. In 2023, the American Geriatric Society updated its Beers criteria, the clinical guideline that identifies medications considered inappropriate or high risk in older adults. Benzodiazepines and Z drugs appear prominently on that list, not because they are ineffective at producing sedation, because in adults over 65, the accumulated risks outweigh the benefits in a way that has become impossible to ignore. Here's the mechanism. These medications enhance the activity of GABA, the brain's primary inhibitory neurotransmitter. They are sedating. They produce the subjective sensation of having slept, but what they do not produce is the architecture of restorative sleep. Slow-wave deep sleep, the phase during which your brain's glymphatic system clears metabolic waste, including the amyloid proteins most prominently associated with Alzheimer's disease, is suppressed by these medications. You feel sedated, you wake up unrefreshed, and the critical waste clearance process that only deep sleep can perform simply does not happen. Research published in the BMJ followed thousands of older adults and found a significant independent association between long-term benzodiazepine use and elevated risk of Alzheimer's type dementia. This is not a fringe finding. It has been replicated across multiple independent populations in multiple countries over more than a decade of follow-up. The second mechanism is one every emergency physician knows and almost no prescribing physician communicates. These medications affect balance, reaction time, and coordination. In adults over 65, falls are the leading cause of traumatic injury and injury-related death, a medication that sedates you through the night and then impairs your coordination when you get up at 2 a.m. To use the bathroom is a documented, measurable fall hazard. The gap is not in the research. The gap is in telling the patient. What I would do instead, address the actual root cause of the sleep disruption. In most adults over 60, poor sleep is driven by one or more of the following: suppressed melatonin production from evening light exposure, elevated nighttime cortisol from chronic stress, undiagnosed sleep-disordered breathing, or the fluid redistribution pattern where leg edema reabsorbs at night and forces repeated bathroom trips. Each of those has a specific non-pharmacological protocol. For the melatonin piece specifically, 2 tablespoons of tart cherry juice concentrate in warm water 90 minutes before bed. Tart cherries are one of the richest natural food sources of melatonin precursors and have demonstrated consistent efficacy in improving sleep onset and duration. Magnesium glycinate, 300 to 400 milligrams taken 60 minutes before bed, supports natural GABA activity without suppressing sleep architecture. And the 4-7-8 breathing technique: inhale through the nose for a slow count of 4, hold gently for 7, exhale completely through the mouth for 8, activates the vagus nerve and measurably reduces circulating cortisol within minutes. Practice it 4 cycles every single night before sleep. If you are currently on a benzodiazepine or a Z drug, please do not stop abruptly. Withdrawal from these medications must be managed gradually and under supervision. Abrupt cessation carries real clinical risks. What I am suggesting is a deliberate, informed conversation with your prescriber about whether the medication is still serving the purpose it was prescribed for and whether a supervised tapering protocol with alternatives introduced is something worth exploring. Consider someone I'll call Harold, 69 years old, retired electrician, practical man, not given to complaining. He walked into a consultation carrying a list of 4 medications he had been on for years: a statin, a proton pump inhibitor, a calcium supplement, and a sleep medication. He was there because he was exhausted all the time, his legs ached constantly, and he kept losing words, small things, but it was happening more frequently and it frightened him. His standard labs looked fine. That word, fine. Cholesterol was controlled. No acute findings flagged. But when someone looked deeper, B12 level, serum magnesium, CoQ10, fasting insulin, the picture that emerged was not fine at all. B12 was critically depleted. Magnesium was sitting at the absolute floor of the reference range. CoQ10 showed significant deficiency. And the sleep medication he was taking every night was suppressing the deep sleep phase that would have cleared the metabolic waste accumulating in his brain. None of those depletions had ever been monitored. None of them had ever been connected to the medications he was taking faithfully every morning because a doctor had told him to. 6 months later, CoQ10 added, B12 supplementation started, magnesium glycinate before bed, a supervised taper off the sleep medication with alternatives in place. Harold described feeling for the first time in 3 years like his mind was working again. Not a miracle, a mechanism identified and corrected. Here is what I want you to walk away with tonight. 1. If you are taking a calcium supplement, ask whether it is paired with vitamin K, 2 in MK7 form, and with magnesium. If it is not, the routing instruction is missing and the calcium has no reliable destination. 2. If you have been on a proton pump inhibitor for more than 3 months, request a B12 level and a serum magnesium at your next appointment. Ask directly about a tapering schedule and root cause management of your reflux symptoms. 3. If you are on a statin, add ubiquinol CoQ10 at 100 to 200 milligrams daily with a fat-containing meal. Ask your prescriber whether your cardiovascular risk score has been recalculated since the medication was first initiated. 4. If you are taking ibuprofen or naproxen regularly for pain, ask your doctor to check your kidney function with a current GFR measurement. Discuss topical anti-inflammatory alternatives. The systemic exposure is frequently unnecessary for local pain control. 5. If you are on a sleep medication, initiate a conversation about a supervised tapering protocol. Before that conversation, try magnesium glycinate and tart cherry concentrate for 2 weeks and track your sleep honestly. And 6. The lab tests that none of these conversations will happen around unless you ask for them by name. Vitamin B12, serum magnesium, CoQ10, if you are on a statin, fasting insulin, vitamin D, and ferritin. These are the numbers that reveal how your body is actually functioning underneath the surface, and most of them will not appear on a standard annual panel unless you request them. Your body after 60 is not the same pharmacological landscape as your body at 40. The medications prescribed under one set of physiological assumptions need to be reevaluated as those assumptions change. That reevaluation is your right as a patient, and it begins with knowing what questions to ask. Before you go, I want to know 2 things from everyone watching. How old are you? Write your age in the comments right now. I read every single comment, and the age of this audience directly shapes which topics I cover in the next video. If the majority of you are 65, the next video looks completely different than if most of you are 72. And second, where are you watching from? City, state, country? Leave it in the comments below. This conversation is reaching people I never anticipated, and I want to know how far it is traveling because it helps me understand who needs this information most. If someone you care about is taking any of these 5 medications without understanding the mechanism behind them, send them this video. They deserve this information. They are almost certainly not receiving it at their appointments. The most dangerous health advice is the kind that sounds completely correct until someone explains what it is actually doing inside your body. Subscribe to this channel, hit the like button. We are building toward 100,000 subscribers, and every person who joins makes it more likely that the next person searching for answers actually finds them.